Okay, why don't we get started? It's noon and we've got a great seminar today. I'm Rex Townsend. I'd like to acknowledge Paladin for their support of the ATI seminar series, and also recognize the land acknowledgement that the University of Alberta acknowledges that we are located on Treaty 6 territory and respects the histories, languages, and cultures of the First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. Today, I'd like to introduce our speaker, and it's a pleasure to do so, Dr. Amanda Van Beinum. Dr. Amanda Van Beinum is a Social Science and Humanities Research Council postdoctoral fellow at the University of Ottawa, Faculty of Common Law. She finished a Master's of Science in Epidemiology at the University of Ottawa and then continued on to complete a PhD degree in Sociology at Carleton University. With interdisciplinary training in science and sociology, Dr. Van Beinum has studied the social, philosophical and theoretical elements of the dying process amidst advanced life-sustaining technology in critically ill patients. She's interested in how science and society intersect and the impact of this intersectionality on medical practice. Dr. Beinum is also involved in an interdisciplinary project called Hybrids Minds, which aims to provide the first systemic exploration of the experimental, ethical, and legal significance of the functional integration of implanted brain devices in the human mind. Just as an aside, being a critical care physician and dealing a lot with the end of life issues in critical care as well as donation, I think this is going to be a fascinating talk. And certainly I would encourage everybody to ask questions and engage with Amanda after the talk. And if we can, just to facilitate, if you could just put your name in the chat box, either a comment or a question, then we'll just facilitate to make sure that everybody gets an opportunity to ask those questions to Amanda that wishes to. And now with that, I would like to turn it over to Amanda.
Great, thanks. I'm just gonna share my screen here. Okay, hopefully you can all see that. Okay, so thank you very much for the introduction and for inviting me to speak with you today about family experiences with non-therapeutic research on dying patients in the intensive care unit. Before I begin, I'd like to share some disclosures. So first of all, I'm coming to you from Ottawa, Ontario, which is unceded Algonquin territory. I also do some consulting work for Canadian Blood Services. I work part-time for the Children's Hospital of Eastern Ontario Research Institute. As mentioned, I am currently starting a position as a postdoctoral fellow at the University of Ottawa, and I have funding from the Social Science and Humanities Research Council. Okay. I also want to acknowledge that the work that I'm presenting today was not conducted alone. This project stems from the larger death prediction and physiology after removal of therapy study, or the DPART study, which some of you may be familiar with. That was led by Dr. Sunny Dinani, and it involved a large number of collaborators across Canada and internationally. The project I'm presenting to you today comes from a sub-study of the DPART study that was led by Jennifer Chandler, who is a law professor here in Ottawa. And the findings that I'm going to talk about mostly come from a paper that was published last year in BMJ Medical Ethics that has a number of collaborators and co-investigators on it who are listed here. So to get started on this topic, I want to talk a little bit about why thinking about non-therapeutic research in dying populations is important for organ donation and transplantation. So non-therapeutic research refers to research that has no expected clinical benefit on the participant and sometimes only carries risk. So even if the intervention works perfectly, the outcome is going to be for another group or a future patient, while the participant who's actually taking part in the research carries the risk. This type of research is not that uncommon in critical care populations. We often collect additional blood work or clinical data in the interest of contributing to a better overall knowledge of critical illness, even knowing that those activities aren't going to benefit patients directly. It's also pretty common in phase 1 clinical trials where healthy volunteers consent to test the safety of intervention. Sometimes when non-therapeutic research has no or only minimal risk, it might qualify for a waiver of consent. However, even minimal risk non-therapeutic studies can pose the risk of what's called therapeutic misconception, where participants who consent to the research, even though it's non-therapeutic research, believe that just being part of a research study is going to help them in some way. Non-therapeutic research becomes a bit more complicated when it's proposed in imminently dying patients. So when death is expected and will occur within hours, such as what we would expect when a patient with no hope of recovery is removed from life-sustaining therapy. These patients are almost never conscious, so they are unable to make research decisions on their own. In addition, they're expected to die, so it's going to be impossible for them to ever affirm a decision about research made on their behalf by a substitute decision maker, as sometimes occurs in other critical care studies where patients are asked later on to affirm the substitute decision maker's consent for research. That can't take place if the person died. Finally, death is an intense and important life transition. It's a moment in which both patients and their families are emotionally and physically vulnerable. And as such, this population is often afforded special ethical protections. So research ethics boards tend to err on the side of providing extra space and comfort to this group, and tend to perceive research on the dying as an added burden for both patients and families. So a proposal for a non-therapeutic blood draw with dying patients, since it has no expected benefits to offset what are assumed to be this additional burden, it's often met with gatekeeping activities, such as prolonged time for ethics clearance, issues with obtaining funding, lack of buy-in from investigators or other collaborators, or sort of unusual requests by the ethics boards, such as the request to have an ethics consultant present at every consent interaction, which was something that we did see at one of the sites in the DPART study. So these challenges aside, non-therapeutic research on dying patients is important, and especially so for improving the practice of deceased organ donation, especially for deceased organ donation after circulatory determined death, or DCD. When I mention organ donation in this presentation, I'm mainly referring to DCD organ donation. So as many of you are likely aware, in DCD, unlike in donation after brain death, the period after determination of death and transition to organ procurement or to the OR is quite short, usually only about 5 minutes. So as a result, any intervention to try to improve organ quality for the recipient, so giving heparin or changing how certain interventions are performed or removed, has to be done while the prospective donor is still alive. Since these interventions are done for the purposes of improving transplanted organ quality, they have no benefit and may instead pose varying degrees of harm to the potential donor. So there's a lot of discussion and debate in the literature about whether or not these pre-mortem interventions, as they're often called, are ethical. But in addition to concerns about how ethical they are, there's a lot of unanswered questions about whether or not these interventions are actually useful and whether or not they cause the harms that some ethicists speculate that they do. In other words, we need more empirical research on pre-mortem interventions in order to help decide whether or not they are ethical and effective clinical solutions for improving DCD organ donation. Conducting prospective research on pre-mortem interventions for DCD would require the conduct of non-therapeutic research on imminently dying patients. In order to do this, some have argued that the best way forward when this type of interventions present minimal risk to patients is to have a waived consent model where families are not asked for consent to research. These proponents of this strategy argue that asking families for consent represents an additional burden during the difficult time of making end-of-life and organ donation decisions, and that the burden of asking for consent to research is maybe more harmful than any potential harms resulting from a minimal risk intervention, such as collecting data or changing one small thing in how an intervention is withdrawn. Other researchers have argued that substitute decision makers want to provide consent and want to affirm the patient's desire to participate in research, especially when patients already wanted to become organ donors. We also have evidence from recent prospective studies of non-therapeutic research in dying populations that substitute decision makers do tend to consent to this type of research, and they do so at a relatively high rate. So the DPART study had a 94% consent rate for the larger study, and I believe it was around the same, if not higher, for the pilot study, which was conducted almost 10 years ago now, actually. So the growing importance of non-therapeutic research in dying patients, especially for DCD, and the unknowns about how families experience this type of research and whether or not they want to be asked for consent or not, led us to this project where we sought to find out more about how families experienced the process of consenting to and witnessing minimal risk non-therapeutic research on imminently dying patients. Specifically in this particular project, we wanted to know whether or not families perceived the consent process to be burdensome, why they provided consent, and whether or not they experienced research procedures as impacting the dying process and their ability to be with their loved ones during the dying process. As I mentioned previously, this analysis, which is a qualitative analysis, it's part of the larger qualitative sub-study, which was itself part of the larger quantitative DPART study, so the death prediction and physiology after removal of therapy study, which was the results of which were published last year. Briefly, for those of you not familiar with that project, it was a prospective observational study that involved the collection of physiologic and clinical data on dying patients in the intensive care unit, beginning 15 minutes prior to withdrawal of life-sustaining therapies and continuing for 30 minutes after the determination of death. Brain dead patients were excluded from the study. However, potential DCD organ donors were included, although they made up only a subset of the total 600 patients who were enrolled. So the qualitative project that I'm drawing data from for this presentation took place at 8 Canadian sites, I believe all of which were in Ontario, and there was one in Halifax. So it was enrolling families of patients who were eligible for DCD, and they were invited to participate in follow-up interviews about their experiences with decision-making for withdrawal of life-sustaining therapies, organ donation, and research participation. So it was only a subset of the questions that asked about research participation, and that's the data that I'm presenting today. So of a total of 48 families who participated in DPART and made consent decisions on behalf of a patient eligible for DCD organ donation, 28 of those families agreed to participate in a follow-up interview. Some families included more than one family member in the interviews. So in the end, we ended up interviewing 33 people, made up mostly of the parents, siblings, and spouses of patients who were potential donors. One family also consented to additional EEG monitoring for the patient as part of the DPART study, but otherwise, all of these families were making decisions on behalf of patients who went forward with the normal DPART protocol, which was just data collection. So after speaking with these 28 families about their experiences with research, here is what we found. First, in terms of their experiences of consenting to research, participants most commonly reported not really remembering being asked for consent in the first place. As one participant summed up, their time in the ICU was all kind of blurry, which made remembering and pinpointing specific conversations difficult. Families talked about being focused on other decisions, such as the decision for organ donation and the decision for withdrawal of life-sustaining therapies, and they tended to lump consent for research in with these moments as just another paper to sign. Family members that did remember consenting to research recounted not being concerned about this minimal risk research project, and seemed to understand it as part of the general clinical process of the ICU. One participant mentioned it was something that was just going to be done. They were in a teaching hospital. They weren't concerned with additional data collection being a big deal. In terms of reasons for consenting to research, so we did ask everybody why, because everybody did consent. That's why we were able to contact them. So we did ask them to reflect on why they provided consent. And families were all able to provide a reason. The majority told us that it was about helping others, contributing to the furthering of scientific knowledge, and that research was in line with their and the patient's values of altruism and general curiosity. Some families also described research participation as part of an overall process of meaning making that took place through the dying process. As a family member in interview number 16 states, the research study was a way of making the patient live on in certain ways, to be able to say, hey, my dad did this, you know, we did this, and maybe some good will come out of it. For this family member, the justification for participating in research was part of ensuring that the patient made a lasting contribution through his death. This type of justification for research participation was also mentioned by family members of patients of potential DCD donors who were ultimately unable to donate, either due to medical exclusions or not dying within the time limits required, so that 1 to 2 hours after withdrawal of life-sustaining therapies, after which DCD donation is not possible. As the family member in interview number 20 explained, and in the end, that was A. He was so interested in data and research and teaching that if we couldn't have donated, you know, his organs, at least something was given back to science, which I'm very grateful for. For this family member, research participation appeared to provide an opportunity for meaning making that was ultimately not possible through organ donation, despite this patient's desire to donate. So lastly, when we asked families about their experience of how the research process went, so what was it like having someone come into the room while the patient was dying to hook up a computer? So in some sites, there was an additional laptop. In some centers, research coordinators had to go in and change some of the settings on the bedside monitor. Or in other centers, research coordinators could gather the data from outside the room. But in all cases, it was usually an additional person who was around during the dying process. So when we asked families how that went for them, most reported that it was not intrusive and did not impact their ability to be with the patient during the dying process. Again, they stated that they were not really focused on the research process, but rather on what was happening with the patient in terms of withdrawal of life-sustaining therapies. Several mentioned that they may have felt differently if the interventions had been more invasive. And finally, more than one participant seemed unable to separate out which of these processes were done for research purposes, which were done for clinical purposes, and which were part of the process of organ donation. So what do we make from what we heard from these families? The major findings of the study. So first of all, the process of consenting to non-therapeutic research on dying patients did not seem to be generally perceived as burdensome. In fact, it appeared to almost not register for many families who are busy focusing on the process of organ donation and withdrawal of life-sustaining therapies. However, despite not really remembering signing the papers, as the one participant called it, all families had well thought out reasons for why they chose to have their loved one participate in the research project. Importantly, for some families, having the patient participate in a research study seemed to allow them another route for giving back and making meaning out of the patient's death. For these families, the choice to make this into a waived consent study may have actually deprived them of the opportunity to feel that their loved one had made an important contribution. So the ability to have research as a meaning-making opportunity might be especially important for families, and especially in cases where patients consented to organ donation, but ultimately were unable to donate organs. Another important finding from these results was the potential for some families to confuse processes of research, organ donation, and regular clinical care. So instead of the classic therapeutic misconception with non-therapeutic research, where participants falsely believe that an intervention will help them, we found that none of the families thought that consenting to research was going to prevent the patient from dying or change anything about their dying, but they did have some difficulty separating out which processes, as I mentioned, were clinical, which were for organ donation, and which were for research. So none of the families in our study mentioned any negative repercussions from this confusion for the DPART study, but it's not difficult to imagine that this inability to distinguish between these roles could lead to perceptions of a conflict of interest or the false understanding that they needed to consent to multiple of those clinical processes, even if they only wanted to participate in one. So the false belief that to agree to withdrawal of life-sustaining therapies, they necessarily had to also participate in research or say yes or no to organ donation. So these findings have practical implications for planning future non-therapeutic research on dying populations, such as those that might be required to test out pre-mortem interventions for DCD. First, as we propose in more detail in the paper, the possibility that families may derive benefit from consenting to this type of research seems to suggest that we need to give more consideration to family perspectives, including the risks and benefits shouldered by families when we design research projects. So instead of imagining that all the harms and benefits accrue directly to the patient, models that consider how the patient is always existing in relation to others. So for example, relational autonomy, where individuals are granted autonomy only through being in relation to other people, better account for how risks and benefits are actually shared, especially in critical care situations where patients are not likely to be making their own decisions in real time. Second, families' perception of the integration of research, donation, and clinical care processes suggests that we need to do better both at clarifying and communicating these different roles, but also in making sure that these groups are working together and are aware of each other's tasks. The prevailing ethical norms that clinical and donation work have to be neatly separated might not actually make sense if families already perceive this work and these processes to be closely connected. In addition, families appear motivated to consent to research for similar reasons as they provide for consenting to organ donation. So reasons such as altruism or giving back to society. This suggests that perhaps in the future, consent for organ donation and consent for research to improve the process of organ donation, so for example, a trial of pre-mortem interventions, might be able to occur at the same time. Of course, this is just a proposal, and figuring out whether or not this was feasible would require more research and especially further consultation with families. So before I close and take questions, I want to draw your attention to a number of important limitations which really restrict how far we can generalize this work and this analysis. So first of all, as you may have noted, we only spoke to a little over half of all the eligible families. So there's a possibility that the other half of families who chose not to speak to us had different experiences or had different opinions about how research went for them. There was also a delay in when we spoke to the families, which may have led to a limited ability to remember research experiences. So we spoke to most families within 6 months to a year, and definitely a few of them mentioned that they perhaps would have had clearer memories had we approached them earlier. Finally, this work only relates to experiences with minimally invasive non-therapeutic research. So it's also likely that experiences would have been different if the research process had involved blood draws or experimental drugs, for example. And a few families did explicitly mention that to us as well, that perhaps they would have had more resistance or aversion to the research had it been more intensive. And lastly, we are missing information here from the research coordinators who obtained the consent, as well as the bedside staff who had to facilitate the research process during when the patient was dying. So further research would consider perspectives from those groups as well in terms of drawing conclusions about how feasible non-therapeutic research is in dying populations. So in conclusion, our study suggests that rather than only being a risk and a burden, the opportunity for patients to participate in minimal risk, non-therapeutic research during the dying process may be a route, in addition to organ donation, which helps families process and make death meaningful. Whether or not these conclusions hold as researchers begin testing out more invasive pre-mortem interventions remains to be seen. However, we propose that our study suggests that this type of research can and should go forward, and that it should involve prospective consent from families. So, thank you.
Great.
I welcome your questions and suggestions as well.
Thank you. That was excellent. So if we can just to give everybody a chance on Zoom, if you can just put your name into the chat box of a question or a comment, and then we'll just go in order. And then you can unmic your mic, and then we can engage in a conversation. The first up is going to be Murray and Donna kind of had some comments that they were sharing in the chat box. I'll just call on Murray first, then Donna for their comments.
Hi. I think this is incredible research that you're doing. It's very important. I'd like to, if you've got comments about what the practicality of advising your lawyer to do with regards to your papers so that this can go ahead in an efficient manner.
Sorry, I'm not sure I follow the question.
So if one wishes to allow pre-mortem analytics to be done, how does one ensure that your lawyers have the paper in place to actually do that and your family understands it very, very clearly?
Okay. From the patient's perspective. Thank you. Yeah, it's clear now. Sorry, I thought you were talking about from a research ethics board perspective. I got a bit confused there. So I'm not sure. I think it would involve just speaking with your family. I'm not sure on the legal side of it whether you could have a legally binding paper that would mandate that you were able to participate in research. As far as I'm aware right now, the research participation and organ donation are two separate consent processes. And I believe even for organ donation in most places, if the family has to provide consent, and in some cases can override the patient's consent. Even if they have agreed to organ donation, the family can still say no.
I think that's exactly the point. What if one wishes to have a patient that might end up dying, wishes to make oneself available for this kind of scientific research, and in the hospital setting where there may not be families around, how does one get that to be put in place? Sorry, I'm rambling.
No, that's great. Thank you. I wonder if we have any research coordinators on the call who could speak to this. My understanding of it, I am not a research coordinator, but I did work with research coordinators for years. And in the case where there's no family, which is quite rare, usually my experience was they would find some cousin or brother or nephew somewhere. But if not, there's like a designate of the state who steps in to make decisions. And so in that instance, I would imagine that having something written in your will would help guide them. But I don't know if somebody else can speak more to that point. That's not something that we investigated in any detail in this research, but it is an interesting question about sort of override decisions at the bedside.
Just before we go to Donna, is there anybody on that may have some expertise into answering that question?
No expertise, just an opinion. And I think perhaps, I don't know if we need yet another document, but perhaps one could be attached with the EMR and appointing a substitute decision maker, or perhaps with around your papers to express your wishes. I don't know if you almost have a contract with your substitute decision maker or something like that that outlines your wishes, but I imagine it would need to be fairly legal, not just a handwritten, yeah, this is what I want, or a conversation. But I do understand the need for this research, and I think perhaps I'm an organ recipient, so I think perhaps that's my feeling. It has been since I've been about 12 or 13, so that could be coloring that. But I think it's important, and I think it's an important conversation to have with the family, and that just comes up again and again in organ donation.
Yeah.
Now, if you're, depending on the circumstances surrounding your death, that changes everything. If it's made, that might be something totally different because you've already had these conversations, but that is not always the case in death and dying. Made is a very small proportion. Just my thoughts, but I agree with you. It is important to at least ask the flip side of this conversation, at least at this point. I also think perhaps that doing this research may be a more difficult conversation for the researcher, but so valuable than it is for the family. The ones who agree, I can understand where they would not understand the difference between clinical value, prepping for organ donation, pre-mortem, and actually organ donation. But yes, there are 3 different consents. I get that. And perhaps that's more education we need to do.
Yeah, for sure. Some excellent points there. Definitely the one about MAID, so medical aid in dying, and the research surrounding that. So again, none of that was included in this particular study, but I imagine the consent process for research there is different because patients can actually consciously, like, they know what's happening in advance and could consent to that. And I agree that just like wanting to be an organ donor, wanting to participate in research around your death, it would be something you have to speak to your family about. And that's where I included some of those quotes there of the family members we spoke to. Some of them who consented to research on behalf of the patient told us, this was something my husband said he always wanted. He said, I just want to be a guinea pig. I want to be useful to science. So more than one family member told us about that. And so again, I'm not sure a legal document would have come in there, but those conversations with family members were certainly helpful. Thank you for those comments, Donna.
Okay, thanks, Donna. Next up is Patricia.
Thanks very much, Amanda, for a really excellent presentation and really interesting research. We've heard, or I've heard from patients in other contexts that are participating in research studies, that there's a real desire to see the impact of their participation in that research. And so I found it particularly interesting, your finding that families are deriving meaning from their loved ones' participation in research. And I wonder, would that support the meaning that those families are finding in that participation if there was a route to share with them the final impact? The DPART study is a great example. That was a landmark study that was published with huge impact and significant media coverage, and can support sort of awareness building in donation and clinical practice and other important impacts. Do you have thoughts on that?
Yeah, thanks. That's a really good point. And as with all research participation, I think it does, as you said, make a big difference for families to actually see the eventual outcome of the research that their loved one participated in. We do have some projects, or the DPART group had some projects ongoing with family members. I think in some cases it does get a bit complicated when patients die, because there's also this sort of, and especially in critical care situations where patients might be dying in traumatic instances. So in some cases, families don't really want to relive that. I know that was a reason for some families declining research in some cases, was like they had already sort of made their peace with what happened. They processed it. They didn't want to relive it. I'm not sure, I'm just speculating here, but I'm not sure that that would be the case for following up with families to sort of tell them more about how the research process went. But it is interesting that they derived benefit even just from knowing that the patient had, given their data or whatever. So they had sort of already taken the meaning from it, even without knowing the outcome, which is interesting.
Great, thank you. Next, Anne.
Hello, I think you mean me, Anne Halpin. Is there more than one Anne?
Nope, you're up.
Yeah, thank you so much. I put some links there. I was recently just updating personal directive, and I found that I don't know if there was always lots of forms online, but I found it really useful to use those tools, and I shared them with my family so that they knew. Now, whether or not that's enforced, I think is a whole different legal question, but my family knows that I will find a way to come back and haunt them if they don't enforce my wishes. So I think they'll be on board with that. And they seemed understanding. It was actually a good conversation. I think it made them think about what they might want in those situations too. But I have another question for you regarding the recent xenotransplants that were done, the kidney transplants in individuals who were, I'm not sure of the exact sort of classification of their brain death or how they were deceased donors, but I think it's prompted a whole nother conversation. Given your experience and expertise with dealing with families and hearing their wishes, do you have any thoughts on that type of research and how families might feel about that, or how many families might be interested in that based on all the conversations you've had? I'd love to hear your perspective.
So sorry, thank you for that question, Anne. I'm just going to clarify. So, because I'm not familiar with the particular study that you're talking about, I think I had read the headline, but hadn't gone into it any deeper. So this is a case of xenotransplant in a patient who is dying, or is there a risk?
No, it's someone who met the criteria for brain death. And again, someone else might be able to clarify more details from an ICU or clinician perspective on that, because I'm just a lab person, but they were not, it was the kidneys from pigs into people who were essentially donors as a means of seeing. So it's different than the heart transplant. That was a different scenario to test for safety, I guess, and whether or not there was renal function, but using this opportunity. And I think it's a really interesting question, and I think that it's obviously these families consented to do this, or it wouldn't have been done. But I wonder how many families would be interested or agree to that. Sounds like a lot of, like the comment, the family number 20 that you described, like that would maybe be their kind of perspective too, like, oh, this person can't be a donor. They would have wanted, my loved one would have wanted to have been a donor. This is a wonderful way for them to contribute to science. But until I was reading these reports, I honestly, I hadn't thought of that possibility, from my perspective. So I wondered if you had any thoughts on that.
Yeah, okay, thanks for clarifying. So a number of interesting things going on there, I think. One is with research with brain dead patients, which again was not the population for this study, but which I have done quite a bit of reading about. So the first question of would families consent to this type of research? So I mean, as you mentioned, they did, I guess, for this particular project. And I think what we found in our work, again, with patients with a different population, is that it doesn't hurt to ask. So even though it might not be all families, and even though some people perhaps have an aversion to it for some reason, there actually are a significant number, or maybe a surprising number of families that do want to find meaning in the dying process and do see clinical research as a way to do that. So I think it is possible to get consent, and I think it is important to ask for consent, even when the research project, from a researcher perspective, feels like, oh, I don't know who would consent to this. I think like we'd be surprised, and it is worth it to talk to families. The second piece about that is about doing research in brain dead patients. So, and this is where like the ethics gets kind of interesting. So because in Canada, brain death, and in many countries in the world, the neurological criteria for death determination is, I mean, that's legal death. And so research actually doesn't, research ethics boards have a mandate to protect the well-being of living patients. So once a patient has been determined dead, research ethics changes a little bit. So the use or involving brain dead patients in research, there's again some blurred lines there about what types of consent need to be asked for. There are protections for cadavers. So you know, and this is what guides sort of medical dissections and that kind of stuff. And the bodies of patients are protected, and we do have that in research ethics, but it does get a little bit different because you're not having risks for pain and that kind of thing. And so again, there are people who argue that, oh, you know, we're only going to be causing more burden on the family to ask for consent to do this one thing in the brain dead patient who is dead anyway, and it's, you know, not going to make a difference. But based on the findings from our study, I would argue that it is worth it to talk to families about it, not only so that they are aware, which just seems like the right thing to do, but so that they could possibly get some benefit from knowing that their loved one did help make a contribution to science.
Great, thank you. Next, Linda Powell.
Thank you. It was just a comment that in these discussions, there's so much conversation about the opportunity to support the family in such a difficult, grievous time. And the gift conversation is so important. And you had mentioned the importance of the communications and skills of the staff at the bedside, whether giving care or whether coming in for another purpose. And I was just making the comment that it speaks to the importance of resources to support that component. We hear the words compassion, caring so often, which is so wonderful and so important in supporting the family, and to give them that opportunity to move forward with that grace of understanding the gift, I think is a key part of this within that research context as well. I've often heard that we should be asking families if they wish to donate. It's that legacy that they would not understand until it happens. And probably the same for research. It's a component of that gift. So just a comment, but important for resources to do that.
Absolutely. Thanks, Linda. Yeah, that's a really good point. And the number one resource I think that we, in my understanding from these interviews, was time. So whether it was a research person, a nurse, a physician, or an organ donation coordinator, families that had really positive experiences were always really pleased with people who took the time either to sit down with them and listen to, you know, their recounting of what kind of person the potential donor was, or answered all their clinical questions, or showed them the brain scans, whatever it was time. And I know that's in short supply in a lot of ICUs right now. So impacts across the board when we don't have that available.
Okay, thank you. Let's go to Gary.
Hi there. I just about the point earlier about advanced directives. I think it's always been an issue in ethical issues. How do we make sure people get their wishes respected? So I just put in the chat that I think for those people who really want to make sure that their family doesn't override their wishes, just to be aware that a few extra steps in their personal directive is probably worthwhile. Now, I just wanted to add the reality that we're almost always dealing with with families who are experiencing grief. And so, I think the more we learn about grief and its dynamics, which I think are amazingly consistent, I think we can make this a part that helps in the grief management of such patients. It's interesting that I'm sure the vast majority of people are willing to help out, but I think we still have to go through the motion of really asking nicely every time and never appearing to be presumptuous. I think those would be the keys. Did you learn anything in your research about, sort of reading between the lines of people's motivations? It sounds like you got that impression that the vast majority are willing givers. Is that the impression you got?
Yeah, so of the families that we did speak to, but there were like just under half that either were lost to follow-up or that we weren't able to speak with. So of those that we spoke with, they were willing participants. They understood why it was necessary. A few of them even mentioned like, wow, it's got to be really hard for somebody to ask me this at the bedside. And I appreciate that. And I also appreciate that, this is important data and that this makes sense. And this is what my loved one would have wanted to do. So for sure. But again, further work, we would have to sort of follow up with those folks who didn't have a positive experience and to understand where they were coming from. And that's really a perspective that's missing here.
Great, thank you. Let's go back to Murray. You have a follow-up question.
Oh my goodness, I didn't recognize I was being up. And what I'm curious about, so I'm a transplant recipient 7 years ago, and I'm very pro analytic science. Why is it that family members that are ill-informed can control what goes on if the individual that's about to die really is quite happy to be part of science? Why? I don't understand that at all. Anyway, so I'll be quiet now.
Thanks, Murray, for that comment. I know there are a number of folks in the organ donation and transplant community who are concerned about that question in terms of organ donation. I don't know how many folks are picking that up in terms of research participation, particularly, but I have been in some conversations where it relates to organ donation. So where the patient wants to be a donor, but the family says no, which is a subset of donation situations, I guess, in Canada. Most of the time, the patient says yes, and the family says yes, and it all goes forward. But the way I've heard one physician, donation advocate explain it is, he said, I don't want to be the one in the ICU carting off somebody's, loved one to the OR against their wishes. And that practically it just was going to cause more harm and confusion and anger than the benefit. That was a couple of years ago, so I don't know how much things have changed. I know there are lawyers who are, interested in this too, because there's a legal aspect about the consent and autonomy and that kind of thing. But I think practically it can raise some issues. I don't know, again, if I'm not a clinically trained person, so if there are physicians or nurses or coordinators on the call who have been in that kind of situation who could speak to it. But.
Well, I'm not clinically trained. I'm clinically observed in various ways. But I mean, why shouldn't it be really quite easy for those of us that think that scientific research is important to future healthcare, to make sure you guys can do all the things that you want to do. I mean, that's the real issue in my little mind. Thanks. I'm going to sign off here.
Great, thanks, Murray. Karen, do you put a couple articles that were up for discussion? Do you want to make a comment about either of those just before we go on to Andreas? Maybe Karen signed off. Andreas.
I think those were just the links to that Xeno pig transplant kidney study. So I think that's why she posted them. Yeah, thanks.
Yeah. Andreas.
Yeah, thanks. Thanks, Amanda, for the talk. I had to step out briefly during the talk, so I missed a little bit, but I did sit in on quite a number of conversations during the DPART study. We enrolled quite a lot of patients in Calgary, and generally, you know, the consent rate, as you pointed out, was very high, and people were very supportive and positive about the study. But of course, it just involved essentially parking a laptop computer in the corner of the room. So it really wasn't a particularly burdensome, invasive, risky type of intervention. Potential donor interventions range from being fairly minor, you know, maybe a pharmaceutical, to being more invasive, you know, potentially cannulating a patient prior to death. So I'm just wondering if you explored that at all as part of your interview with families, specifically whether a more interventional type of study would have altered their perspective potentially, or if the degree of invasiveness of the intervention would be important in whether or not they would consent. Thanks.
Yeah, thanks, Andreas, for that question. So we did not explicitly ask all of the families about whether they would agree to a more invasive intervention. A number of families voluntarily brought up the issue of blood draws, and they specifically sort of mentioned, you know, oh, the data collection was fine, but if it had been blood draws, if they had to put, you know, him or her in pain to do the research. So, which I think, like, the idea of getting a needle kind of, because of its connotations, sort of viscerally, people with, you know, having blood removed from the body, it has this connotation as being a very invasive process. So a number of families did sort of compare what happened for DPART with just the computer and the data with that type of research, and said, like, you know, that might have given me pause just for them to have more blood draws. At a certain point in our interviews, and as part of the DPART study, one of the centers, I believe one of the centers that was doing additional monitoring was considering adding video monitoring to DPART patients during the dying process, because there was some concern that we were seeing artifacts in the art lines because of families moving the bed. So there was this proposal to put a video camera in. And so before they did that, which they never ended up doing, but at that time, there were a few interviews with families going on, and we added on a question to ask families, would you have allowed video monitoring? Several families thought that was quite weird, that we were asking to take a video camera or a video of the patient dying. And yeah, definitely a few of them said that they would not have consented to that was sort of a strange add-on. But just the same, there was more than one family that said that they would have been fine with it. They had already agreed to research, and at that point, they were going to say yes to any kind of research intervention that was going to go forward. So again, I think even it kind of ties in with Anne's question about the research xenotransplantation on brain dead patients, that I think there will always be a handful of families that are going to consent, even if it's to cannulation or something that's significantly more invasive. And I think that's where you get people maybe who are like Murray, who was speaking earlier, who are really keen on this analytic aspect of healthcare, and they really personally believe in furthering the medical institution. And I think when a patient like that is involved and has told those views to their family, and the family really wants to further that patient's intentions, I think that's sort of like the best case scenario for research. And in those cases, those patients might be, and families might be really willing to participate in that kind of research. Of course, it won't be everybody, but I think there are those patients out there who would be willing to contribute in that way.
Great, thanks. Andres, any follow-up to that from your perspective, being on the organ and tissue side as well as research perspective?
Well, that's really interesting. I mean, I think on first read, I might have interpreted the really high consent rate as indicative that families are very, very supportive of donor research in general. But I do think we have to be careful in concluding that based on that, particularly just because of how simple the DPART intervention was, right? And you know, obviously, research on donor interventions is important, and I think we're going to increasingly see that type of research in Canada. So it'll be interesting to see whether how high consent rates are in comparison to DPART once we start asking families to participate in asking families on behalf of their loved one to participate in those types of studies.
Great, thanks, Amanda. I'll give you the last thoughts on that before we sign off here.
Yeah, thanks. Yeah, I would agree for definitely. And I think that just one thing we can take from this is to not assume about families, and to both not assume that they will participate in research, but also to not assume that they are going to be against it or find it strange or invasive. Instead, as I believe somebody else mentioned, we have to give families the benefit of the doubt and give them the opportunity and do the work, which is resource intensive, of asking nicely. And I think in some cases we will be pleasantly surprised, and we will find those patients and families who are really motivated, and it's data from those opportunities, or from those people and families, that's going to be really helpful and important for improving the process of organ donation.
Great, thank you. With that, I'd like to thank everybody for coming into rounds today and to offering to our academic time here, and thank Dr. Beinum for this excellent conversation and talk and leading us through this journey. And our appreciation and thanks go out to her. Just to remind everybody that next week's ATI seminar, we're very pleased to have Dr. Vanessa Gribben presenting on organ donation following the medical assistance in dying, legal and ethical considerations. I think this is going to be fantastic, just because of the number of patients that we're starting to see, or an increased number of patients we're starting to see with that are actually offering to be organ donors after they've made that very challenging decision to go through MAID. Certainly for them and their families. And just a reminder, the CDTRP has launched the Research Innovation Grant Competition for 2022 with the support of Paladin. The ATI is delighted to offer 3 additional awards specifically to Alberta-based research teams. The deadline is on April the 11th, 2022. The links are in the chat box for anybody, and the ATI can send that to everybody. So Amanda, thank you again very much. Appreciated your time and your excellent talk, and thank you for everybody for participating.
Thank you. Bye, everyone.